first case presentation would be by Dr. Mahendra Singh. It's a case of, we'll start with head and neck, move on to breast, then abdomen, and also the inguinal region, and finally into the lower limbs. Now over to Dr. Mahendra Singh.
Good afternoon everybody. I am presenting a case of 51-year-old lady, Lalmati Devi. She is a homemaker and she is a resident of Patna, Bihar. She presented in surgical OPD with chief complaint of swelling in front of neck since 1.5 years. She was apparently normal before 1.5 years when she noticed a small swelling in front of neck, which was more on right side, which was insidious in onset. Initially it was 2 into 2 centimeters. It slowly progressed and attained the present size of 6 into 6 centimeters within a span of 1.5 years. Swelling is not associated with pain and fever. There is no history of alteration of voice. There is no history of difficulty in swallowing. There is no history of difficulty in breathing. He is giving history of chest pain during exertion since 4 years. History of palpitation since 4 years. And he is giving history of facial puffiness, facial swelling since 4 years. It is on and off and more on morning. And he is giving history of joint pain since 4 years. It is more in larger joint, shoulder joint, elbow joints, knee joints. It is more in early morning and relieved by oral medication.
The joint pains.
Yes, sir.
No, it's a she, right?
Yeah, sure.
Before you forget, right?
Relieved by oral medication. There is no history of loss of weight, loss of appetite. There is no other history suggestive of hyperthyroidism or hypothyroidism. There is no history suggestive of distant metastasis. There is no history of any chronic comorbid illness. There is no history of radiation to head and neck region in the past. Now, she is having 2 episodes of biliary colic in the past. Personal history. She is having normal dietary habit. She is non-vegetarian. She is not an alcoholic, not a smoker. Bowel bladder habit is normal. And sleep pattern is normal. Menstrual history. She attended menopause 3 years back and cycles were regular previously. And she is having 3 live issues. Treatment history. According to patient, some needle was inserted and tissue was taken and sent for examination 5 months back.
You think that is FNAC?
FNAC.
Okay.
Subject now history competency.
Any questions in the history, Samrat? Salim? Now I have a few questions. You started off by asking about history of bone pains or joint pains. What was that?
Sir,
She gave the history or you wanted to know?
sir, now she told that she is having complaint of joint pain and chest pain during exertion. She
Okay.
gave the history.
Okay, fine. You took the history of exposure to radiations.
Yes, sir.
Why is that history important?
So in childhood, if radiation is given, low dose radiation is given, it is more prone for thyroid malignancy,
Which thyroid malignancy occurs due to
capillary
radiation?
carcinoma.
And what dose is the optimum dose?
So low dose, less than 20.
And what age is the right or wrong age?
In childhood, so less than 10 years of age.
It's less than 20 years, 20 centigrade dose and 20 years of age, right? So that 20 can be remembered easily. The other thing I want to know is you took history of loss of weight and appetite. What would be a significant weight loss in any patient?
Significant weight loss is 10% of total body weight in last 6 months.
Very right, more than 10%.
More than 10%.
But important word is unintentional. Because if it was intentional, then it won't be significant weight loss. Right? Any questions, Dr. Umesh? Dr. Umesh is recording the findings and we are going to discuss based on that. Although it is going to be an exam-oriented class, I'm not going to divert from what we are doing. And as the questions are put up in the exam, the questions will be put up here also. The other thing was, yes, Umesh?
What are the features of hypo or hyperthyroidism?
Yes,
had asked,
you took the history of
history.
hypo or there is no history suggestive of hypo or hypothyroidism. What do you mean by that?
So hyperthyroidism, there may be CNS symptoms like insomnia, restlessness, excitability, nervousness, and tremors. And there may be severe symptoms like palpitation, chest pain, breathlessness, and there may be eye symptoms like difficulty in vision. And symptoms of hypothyroidism may be facial puffiness, and hoarseness of voice, and lethargy.
Very right. Actually, instead of mentioning each symptom at length and in details, it is a good idea to talk about no such history, and then leave it to the examiner to ask you what are those features, so that you have an advantage of being able to answer it. Is that right? Now, what about the menstrual history?
Sir, menstrual history.
So why did you want to take it?
Sir, in hyperthyroidism or hypothyroidism, in hyperthyroidism there is amenorrhea, and hypothyroidism there is menorrhagia.
So you wanted that history. That's very well answered. Now you also took no history suggestive of metastasis.
Yes, sir.
Why? I mean, what do you mean by that?
So to rule out any thyroid malignancy, we have to rule out any distant metastasis. There may be bone pain, back pain, in metastasis to bones, or any chest pain, cough, hemoptysis, breathlessness, in metastasis to lung or respiratory system.
Is it common to have these metastases happening in thyroid malignancy? Samrat?
So in
Salim?
Sir, it's very rare.
Yes. Which of the thyroid malignancies leads to hematogenous spread?
So follicular is more lead to hematogenous spread.
And which are the common areas where it
So
goes?
bones are most common areas, and spine is most common also.
Very good. So you take that history specifically. That's why I asked you about the joint pains when you were referring to it.
So it is in large joints, sir, not in.
So it's not relevant.
Yeah.
Well, then you took, in addition to that, any history which would be relevant in a woman, in a lady, obstetrics history. Did you take that?
Yes, sir, sir, she's
What is it that would alarm you?
Sir, in hypothyroidism there may be infertility.
Okay, very good. And in anything else that can happen?
Sir,
Anything else that can happen in hypo or hypothyroidism?
sir, creatine is many.
No, she's already grown up to some stage. Anybody would like?
Multiple bad obstetrical history, multiple abortions.
Multiple abortions, miscarriages, that is going to make more sense to us, Right? Now, so far is the history. In the treatment part, you took into account a fine needle aspiration cytology as history. Anything else you'd like to ask specifically?
If she is on drugs like antithyroid drugs or thyroxine.
Very good. How about the family history? Did you miss it or you wanted to skip it? Okay, so don't miss it, it's important. What is a significant family history in a thyroid cancer?
So,
In a thyroid swelling, I'm sorry.
so in medullary carcinoma of thyroid there may be stone pain, bone pain, or thyroid malignancy.
See, you heard that. Stone pain, bone pain. This is how we make it simpler. And it's a rhyme also, right? Stone pain, bone pain. Stone pain is due to?
So, colic.
So you're referring to MEN syndrome. Stone will happen not due to medullary carcinoma of thyroid, no?
Yes, sir.
It will happen due to MEN, parathyroid adenoma, producing hypercalcemia, leading to stones, okay? And similarly, in hyperparathyroidism, it is often said it's a disease of abdominal groans, psychic moans, stones, and bones. The bone stones, abdominal groans, and psychic moans. That is hyperparathyroidism. So that history needs to be taken. That's fine. In the family history, you're missing one more thing. In family history, even in papillary is relevant these days. Can you tell us the genes which are responsible for papillary or medullary? What are the genes for
Red
medullary?
PTC1 oncogene.
Red proto-oncogene for medullary. And for papillary?
Non. KRAS mutation.
One, yes, BRAF.
P53 mutation.
P53 suppressor gene mutation, BRAF mutation, etc. So you should be aware of it, that family history is significant in all thyroid malignancies. Right? Any question, Akash? Yashwal, you're satisfied with the history? Joy? Kriti, satisfied? Any question? Right, Umesh, any question in the history before we move on?
History of any other neck swellings?
There is no stimulant.
Why is it that important? That's an important question.
There have been cervical lymph node present.
Basically, indirectly, to find out if they want to lymph nodes. Fine. Now let's move on to the general examination. Now remember, this would do for any thyroid swelling.
General physical examination. Patient was examined after taking well-informed consent in well-lit room after adequate exposure and adequate privacy. She is conscious, cooperative, well-oriented to time, place, person. She is sitting comfortably on chair. She is not restless, not anxious. Performance status is 90 by Karnofsky. Nutrition status is adequate on account of BMI, which is 22 kg per meter square. Hydration status is adequate. Facial puffiness is present. She is affable to touch. There is no pallor, no icterus, no cyanosis, no clubbing, no generalized nephropathy. Pedal edema is present. Vitals. Pulse rate is 70 per minute in right radial artery, regular in rhythm, normal in volume, no specific character. BP is 120 by 80 mm of Hg, right arm supine position, and respiration rate is 14 per minute, thoraco-abdominal, regular.
Any question? Internal physical examination prediction? Anything that is missed out? Covered? Yeah, Pushpa? Abhinav? Look, you don't have to split them as vitals, then pulse, then blood. Just keep mentioning. It's a postgraduate exam. Undergraduates also don't need to do that. And this is one case where pulse will be important. So don't just say pulse is this much. Now you'll describe the pulse, rate, rhythm, character, synchronicity. For everybody I'm saying. What kind of a pulse do you get in thyrotoxicosis?
So it is a high bounding pulse.
Okay. Any special character?
Pulse rate is increased.
Right, they take care of you.
So this sleeping pulse rate is.
So we are dealing with an awake patient, Anuradha.
So there is
Speak loudly.
so wide pulse pressure, tachycardia, and there is mainly increase in diastolic blood pressure.
Yes, so you get a wide pulse pressure and a water hammer pulse you can get in thyrotoxicosis, which is important. Okay?
Yes, sir.
Now, performance status,
Is 90 by Karnofsky.
did you mention?
Yes, sir.
Good. Nutritional status,
Adequate on account of BMI, which is 22 kg per meter square.
see how comfortably he could cover it because he has those points clear in his head. Performance status, nutritional status and hydration status. And the moment he said nutritional status, he said BMI this much because you're covered. Because nutritional status we already covered in the past would include everything, but he has to cover up with some parameter which he can measure. And hydration status he says is adequate.
Yes, sir.
Okay. Let's move on to, and why did you look for pedal edema?
So in hyper
One is for the nutritional reasons.
Yes,
Any
sir.
other edema which is important in thyroid?
Critical mixed edema.
So how is that different from a normal pedal edema?
So it is a non-pitting edema.
Very good. And where is it confined?
So it is not below the knee, mostly from.
In the shin area, so it's confined to that area. It's non-pitting. Why is it non-pitting, Shipra?
Sir, because of the collection of the mucopolysaccharides.
Speak loudly so that he can
Sir,
record you.
because of the collection of the mucopolysaccharides in the shin area.
Where else in thyrotoxicosis
Sir,
the
in
mucopolysaccharides are correct? Let me complete the question.
Sir, periorbital area.
Where else, Abhinav? Something that leads to exophthalmos.
Retroorbital.
So there are various places where it gets deposited. They've described all the areas and just added one more thing. Let's move on to the local examination, and I'll request Dr. Nikhil to also keep a focus on the neck when you're examining, right? And you need to show us exactly how you would demonstrate each time. You first present it, then I'll ask you to demonstrate, okay? Yes?
Inspection.
Yes.
Inspection was done by standing in front of patient. There is a visible swelling present in front of neck, which is more on right side. It is moving with deglutition. It is moving with deglutition.
Demonstrate movement on deglutition.
Through finger.
This is one method.
Sip of water.
Yeah.
using
What do you do with the sip of water? You ask her to drink it, or you let her keep her in the
Ask
mouth
her to drink.
before? If she drinks it, then you won't be able to see. You ask her to keep it in the mouth, and then when you're examining, you will ask her to swallow, and it moves on deglutition. Why does the thyroid swelling move on deglutition?
It is because of the attachment of the thyroid, because of the pretracheal fascia and the ligament of belly. That is,
Yes, you're right, but can you make it better and speak loudly so that you're heard? You're right.
There is a ligament of belly, that is the condensation of the pretracheal fascia that is connecting the thyroid to the hyoid bone with the
It's not to the hyoid, it's to the trichome. So it moves on deglutition because when you're swallowing, what happens?
Thyroid is invested into pretracheal fascia, which is invested to cricoid. When we swallow, there is superior constrictor of larynx will pull the thyroid up, and cricoid will also pull up. So there is
Very
movement
good,
of
that's a
thyroid.
complete answer, and you don't need to add anything to that, because it's a movement of the cricoid which is moved by the superior constrictor as we swallow. And that is why the history of difficulty in swallowing is important. Difficulty in swallowing is not related to the malignancy, it is the weight of the gland. Sometimes it can be a benign thyroid swelling, which on being pulled up will cause discomfort, right? So that is why this swelling. Which other swellings move on deglutition, Dr. Mahendra?
Subhyoid bursitis and any larynx swelling arising from larynx or
Like
trachea,
which swelling?
laryngeal carcinoma or
Laryngeal carcinoma is not outside. Swellings are in the neck swellings, I'm asking.
laryngeal lymph node.
Laryngeal lymph nodes
And subhyoid bursitis, thyroglossal cyst.
good. Now, I'm glad you did not mention about movement on protrusion of tongue. What do you have to say about that? Titiksha is smiling, so they all have a reason to smile about it.
So this swelling is small, present in midline and
High up
High
in the
up,
midline,
yes,
so
sir.
don't mention it as a routine. Clear? Let's move on. So you inspect it from front, and it is a smart thing to say that I saw it from a distance first,
Yes,
then
sir.
got close, so that you have a good view of the swelling, right?
Yes, sir.
Okay.
swelling is globular in shape, approximately 5 into 5 centimeter in size. Surface appears to be smooth, margins are well defined, lower border can be visualized, and skin over the swelling is normal. There are no scar, no sinuses. There are dilated veins present over the chest.
Why are you so fussy about dilated veins in such a small swelling?
So positive,
No, I'm asking you. Finding it right, I'm asking you a question.
so swelling is small, but sometimes mediastinal lymphadenopathy may present.
Yes, very good.
Swelling.
What else can be there in addition to that? This thyroid can be in two parts. There could be a part which is below. There can be a retrosternal part of a gland.
So the small swelling, lower margin is visualized.
Two separate parts.
Two separate.
So it is significant. And of course, mediastinal lymph nodes. Basically, it's a finding you got to report. Yes, move on.
So having one doubt, sir.
Yes.
If swelling is small, lower border is visualized. There are dilated vein over chest. Shall I do Pemberton or not, sir?
Do a Pemberton and exclude. That's a good question. You will do the indications for doing Pemberton signs. One, you cannot get below the swelling.
Yes, sir.
Before that, there would be always features in history. Patient gives you history of orthopnea,
Yes, sir.
discomfort on lying down, right? And there is a suspicion based on the history of the patient that there is a retrosternal element of the gland. That's one. Number two, on examination, you cannot get below the swelling. Number three, there are dilated veins on the chest wall or features of superior vena cava syndrome. These are features which will make you do a Pemberton sign. If you do a Pemberton, otherwise a small swelling, it will be a waste of time and effort. Let's move on.
Palpation was first exam trachea appears to be in midline, and palpation was done by standing behind the patient. There is no localized temperature, there is no tenderness, there is a non-tender swelling present in front of neck, which is more on right side, moving with deglutition, and it is globular in shape, 6 into 6 centimeter in size, and superior extent. Superior it is extending 4 centimeter below thyroid prominence, inferior it is extending 1 centimeter above supraesternal notch, lateral side. In right side, it is extending 3 centimeter from right border of anterior border of right sternocleidomastoid. In left side, it is extending 1 centimeter from anterior border of left sternocleidomastoid. Surface appears to be smooth, margins are well defined, lower border is well palpated, and it is firm in consistency. Bilateral carotid pulses are palpable at normal place, and examination of cervical lymph node, there is no cervical lymphadenopathy.
Well, we'll take one at a time. Demonstrate the trail sign for looking for thyroid or trachea, whether it's
So index finger and ring finger at the level of middle end of clavicle. Then I will start from thyroid prominence. Then I will go downward,
What is the mistake here?
Fixing that.
fixing the head.
Fix the head. If you don't, it
Then I
is-
will insert my middle finger in between trachea and sternocleidomastoid. If I am able to insulinate or not, then I will take on opposite side.
trail sign has to be done absolutely accurately. It will be a part of your examination. You keep sitting, keep sitting. I'm just trying to demonstrate. expose the neck adequately. Don't shy away from it. Look for the, what are these? These are the clavicular heads.
Clavicular heads.
These two fingers come on the clavicular heads and try to feel for the thyroid cartilage and try to trace it down. Sometimes this will be doing, because if there's no swelling in the midline, there's no problem.
Yes, sir.
And then you go laterally in the space between the sternomastoid and trachea here and sternomastoid and trachea here. You can see that the space here is not very clearly demonstrated, although the trachea is in the central, even otherwise. Sometimes there is a big swelling here and you cannot feel the trachea. Then look for thyroid cartilage. That's a good sign of shifting, because there's no way thyroid cartilage won't be shifted and the trachea will be shifted. So these are the ways to look for it. What other examination you did?
Sir, eye signs.
The palpation. Demonstrate how to do palpate.
So I will stand behind the
Go
patient.
do that.
I will slightly tell the patient to flex the neck, to
Very
relax the
good.
deep fascia.
Right.
Then I will start palpating. First I will see for any local rise of any tenderness. Then I will see for
See, first thing that will happen is the local temperature, you would know as you touch the skin. There is no inflammation, so there is no tenderness.
No
Okay?
tenderness.
And then you look for the consistency. which you
consistency.
did, right?
Yes, sir.
Okay.
Then I will see for lower border which is palpated.
All the borders.
Yes, sir, all the border. And surface appears to be smooth.
Okay. Carry on. Okay. I'm not
Then I
stopping
will
it.
see for cervical lymphadenopathy.
No, finish with the palpation. Anything else? All the borders you have palpated. Size you have confirmed.
Yes, sir. Size.
Are you happy with the size you described?
Yes, sir.
Okay. Then we move on to the demonstration of eye signs, which you mentioned. Where do you look for? Stay there. Where did you feel for the carotid pulsations?
Sir, I
Demonstrate the palpation of carotids.
Sir, I will now fix the head.
Keep doing it.
And flex the
Yes.
head. And first at the level of thyroid prominence, at the end
Thyroid cartilage.
thyroid cartilage,
Okay.
at the anterior border of sternomastoid, one carotid at a time. And I will palpate against the transverse process of C7 cervical vertebra, C6 cervical vertebra.
Very good.
Then for another side, sir.
Do it on the other side. That's the correct way of doing it. Clear? What is the problem in doing both sides simultaneously?
So it can precipitate vascular bleeding.
Yes. One and you're right. Carry on. Just speak the same thing again.
So it can precipitate the vascular attack.
Why?
So because it will diminish the cerebral blood supply slightly.
Diminishing the blood supply should not start a reflex. No? Can you think of something else?
Carotid bodies.
Stimulate the carotid.
Baroreceptors there which will produce this effect. Okay, perfect. Now demonstrate the eye signs. Each one. Signs of thyrotoxicosis. What are the various signs of thyrotoxicosis you looked for in this picture?
Sir, I will look for lid retraction, lid lag, incomplete convergence, exophthalmos.
These are all
and-
eye signs. Are there some other signs also for thyrotoxicosis?
Yes, sir. Also, there may be tremors, and
Demonstrate how did you look for tremors.
I will ask the patient to extend the arm, सीधा करो, and out now. Stretch the fingers, expand the fingers. कैसे करो हाथ? I will look for tremors, and otherwise I can put a piece of paper on hand to
You
look
do,
for
we are just looking. You tell us whether tremors are present or not. If you keep the book, the tremors will go.
tremors are not present, sir.
So this is one method.
Yes, sir.
And you'll switch off the fan, which we had to do anyway. Can you put it underneath put under the hands, the paper? So you can look for the shadow of the slightly lower. And if you throw the torch from above, you see the shadow. And shadows demonstrate movements in a magnified way. You've seen the shadows carrying the hell out of you in the night. They look like big demons, although they're just you, right? And that's because they get magnified, and this shadow sign is one. Now we look for the eye signs. Let's demonstrate that. Somebody mentioned about sleeping pulse rate. So sleeping pulse rate is not a sign you demonstrate. It's something that is done as a part of actually investigations in the night. And sleeping pulse rate is not tested by waking up the patient and checking for it. Patient keeps sleeping and you take it, right? And if the patient has a pulse rate of less than 80 or 84 or 86, even when she's awake, there's no point checking for the sleeping pulse rate. You can't bring it down further. Okay. Now, the signs of thyrotoxicosis, if there are, just don't be focused on eye only. Yes. Am I specifically asking you for eye signs now? Otherwise, tremors, tachycardia. You need to demonstrate that. T and T, moist hands. These are all features. Right, okay, let's see the eye signs now. Please speak loudly each sign and we'll
I will sit at the level of patient and head is fixed by using left
Very
hand, and first I will look for Stelvak sign, which is
In order not to block it, she will stabilize the head for you, yes. But you do it. You
I will
like
first
this.
look for Stelvak sign, which is by
Let us
observation.
all of you imagine that that is not her hand, that is his hand, okay? He's supposed to do it himself. We won't get an assistant to do that,
Yes,
right?
sir.
Okay.
So I am at same level of patient, head is fixed. First
Perfect.
I will look for Stelvak sign, which is by observation. I will look for infrequent blinking and staring look, which is not present.
Demonstrate. Now, how close will you get to the patient?
Sir, at least now 1 meter, half and 1 meter.
1 meter is too far. Unless somebody is thinking, you need to get close. Right? The only problem is, unless you stare, there is no staring that you can observe. So get closer. Get closer. Yes. इनके आँख में देखिए जरा डॉक्टर साहब की. Now, who should blink first, patient or the doctor? Normal person or
Doctor,
if she is sick?
yes sir.
No, she can also blink before. Right? Depends. That is tailback sign. Next,
And I will look for lid lag sign.
demonstrate red lag.
My finger is around 40
Now
cm.
please fix it yourself because she will not be able to assist you there. We just wanted to demonstrate that sign. Now try to give some space.
I will look for lid traction, upper sclera is visible or not, upper sclera is not visible.
Okay.
And I will look for lid lag, I will explain the patient. आपको मेरी अंगुली की तरफ देखना है, ठीक है? मैं इसको नीचे करूँगा तो आपको नीचे लेके आना है, अंगुली की तरफ देखना है. My finger is around 40 centimeter from the patient and patient will follow my finger and there is no lid lag.
Okay.
And Geoffroy sign is also negative.
Demonstrate. What is Geoffroy sign?
Geoffroy sign, when looking upward, there is loss of wrinkling.
Why do the wrinkles disappear? Titiksha, Anuradha, yes.
Because of deposition of hyaluronic
Exactly,
acid.
that's another place which you forgot, the deposition of mucopolysaccharides. And also,
There is a upper field of vision is increased due to
if
exophthalmos.
there is exophthalmos, like a horse, you don't need to turn. The horse is popping eyes, so you can see things. Okay.
Then I will look. Now I will ask test for Mobius sign.
What is that? How do you test for it?
I will explain the patient. आपको पहले दूर की तरफ देखना है, ठीक है? फिर मैं अंगुली लेके आऊँगा तो उसकी तरफ देखना है. Sir, convergence is complete, sir.
Don't do it suddenly. I don't know why. Every time I find that people do it suddenly, nobody can converge. What do you look for? Bring slowly closer to the eyes. Okay, now you look for convergence. Next,
Sir, I will look for the exophthalmos, which is by Nafziger method.
Nafziger's sign. Okay,
I will stand behind the patient and extend the neck, and I will look at the level of supraorbital ridge. If eyes is protruding up above the level of supraorbital ridge, then it is exophthalmos.
fine. Any questions so far, Umesh?
You mentioned about thyroid region. What are the boundaries of the thyroid region? And
Superior
what is
boundary is
significant?
hyoid, and inferior boundary is supraexternal notch, and lateral boundary is the border of sternocleidomastoid.
What is the significance of the thyroid region?
Any swelling present in thyroid region is proved to be thyroid unless
Taken to be
thyroid unless proven otherwise.
Very good, excellent. And which group of lymph nodes did you palpate? Demonstrate all the levels in this patient by putting your finger. What is level? No, just stay there. What is level 1A? Put your finger.
So
And tell us
level
the
1 is
boundaries.
submental.
Boundaries.
Boundary is anterior border of
Anterior
digastric
bellies of digastric.
Anterior bellies of
Very good.
digastric.
Now tilt her head this
and
side.
submandibular.
Tilt her head towards me, then only you can demonstrate. आप इधर देखिएगा माता जी. Tilt her head towards me. Now you can demonstrate. Otherwise you can't demonstrate. Where is submandibular?
Submandibular triangle is present
1B.
between anterior belly of digastric and posterior belly of
Put your
digastric.
finger there. This is level 1B.
Level 1B.
Now 2, 3, 4.
So level 2 is present between base of skull up to hyoid bone. anterior border of sternocleidomastoid. And level 3 is between hyoid and thyroid.
Cartilage.
Cricoid, hyoid and cricoid. It is level 2. And level 3 is between cricoid and supraesternal notch. And
4.
level 4 is between cricoid and supraesternal notch. Level 5 is in posterior triangle of neck.
It is easier if you divide sternomastoid into 3 parts.
Yes, sir.
Do that. Upper 1/3. So that's what sternomastoid.
That is hyoid, sir.
And it's sternomastoid.
Sternocleidomastoid.
Upper 1/3, middle 1/3, lower 1/3.
Yes, sir.
2, 3, 4.
Yes, sir.
Where is level 5?
Level 5 is present in posterior triangle
Put
of
your,
neck.
I mean, ask you to demonstrate it, yeah. Between the boundaries.
Posterior triangle of neck.
So boundaries.
Boundaries is posterior border of sternocleidomastoid, trapezius, anterior border of trapezius,
Good. And clavicle.
clavicle.
Which is the level that is likely to be involved with thyroid malignancy?
So level 6
Where is
and
level 6?
level 6 is present in front
Demonstrate just without looking at me. Put
from
your finger-
hyoid up to supraesternal notch,
Laterally.
laterally up to anterior border of sternocleidomastoid.
Carotids. Carotid sheath, not sternomastoid. That's not correct. Most people read that wrongly. So pre and paratracheal group of lymph nodes is level 6.
Yes, sir.
Is there any lymph node palpable here?
No, sir. No, no.
Okay, so if there is any question from anybody, yes, please.
What are the tongue tremors? Is that important?
Tongue tremors. She's asked you a question.
Oh, there are no tremors, sir.
No, is that important?
Yes, sir. This is important.
How do you demonstrate it?
I will ask the patient to open. I will first explain the patient. आपको मुंह खोलना है और जीभ है ये पूरी बाहर नहीं निकालनी है, जो आपके होंठ है ना यहाँ तक बाहर निकालनी है, वहाँ तक रखना है, ठीक है? हाँ, मुंह खोलिए, पूरा मुंह खोलिए, हाँ ये जीभ यहाँ तक निकालिए, बस होठों तक, बाहर मत निकालिए पूरी,
थोड़ा ऊपर रखिए।
थोड़ा ऊपर रखिए,
जीभ को टिकाना नहीं है।
टिकाना नहीं है, होठों में नहीं टिकाना है, हाँ जीभ को हाँ हवा
Yes,
में
that's
रखना है।
right. She's a very good patient. And where you look for, you will see. Get down. Get down from there only. You see from the lateral side. That's why I asked you to see. Right? They're difficult to demonstrate, and it's rarely a case that you don't have tremors and you have tongue tremors. So you would go for the easier of the two options. Correct. Any other question?
So do we need to do it if there are tremors in the hands?
No, then there's no need to do it. You tell me, is it necessary to do it? If there are no tremors, not necessary. Now,
Sir, trail sign is it can be also, we can see in inspection or it is a palpatory finding.
how do you trail without putting your finger there? Trail sign is by trailing it with the finger only. Okay, not inspecting. You agree?
Yes, sir.
Right.
So, any significance of spinal examination?
That I will mention later, sir.
Now please tell him what is the significance.
For examination of spine cranium, sir, there is a two bony heart swelling present in frontal region. One is around 0.5 centimeter and another is 1 into 1 centimeter. These are fixed to bone. Sir, examination
Did you
of
answer the spine part? See, no head and neck examination is complete without examination of the cervical spine. So we need to do that each time. Right? Any other question?
examination of the spine, pelvis, ribs, long bone appears to be normal. Examination of ear, nose, throat appears to be normal. Examination of other system, abdomen is soft, there is no organometry, there is no free fluid. Respiratory system, bilateral equal breath found is present, there is no tenderness over chest, and CNS, there is no focal neurological deficit.
Excellent presentation. I think it deserves a round of applause. Now we move on to the discussion part.
So
Yes.
it is necessary to demonstrate mobility horizontal and vertical as if it is carcinoma it may get fixed.
Yeah, he mentioned about it being mobile. If it is not fixed, then it is mobile. Mobility needs to be described because carcinoma is not always fixed, but later on it gets fixed.
So if it is moving with deglutition, then
And
there is
secondly, if it moves on deglutition, that itself, but sometimes moving in deglutition means it could be fixed to the larynx and still move. If it is fixed to strap muscles, what would happen is that it won't move on deglutition. So mobility has to be demonstrated. It is necessary, right?
So is there any significance of Cock's test if Horsens is not complained by the patient?
Cock's test is usually done in large swelling. In large multitudinal goiter, it will lead to tracheomalacia, softening of laryngeal and tracheal cartilage. So in large swelling, Cock's test is more significant.
And also remember, Coccus test is done for what? It is done to see whether this is pressing on the trachea or not. A unilateral swelling does not press on trachea. It has to be bilateral before it presses on the trachea. Right? So Coccus test is not mandatory. It's not
Mandatory.
right. Any other question? Okay, can we move on? So let's summarize your case.
So 51-year-old lady presenting with swelling in front of neck for last 1.5 year, insidious in onset, and attended the present size of 6 into 6 centimeter. There is no pressure symptoms, no history of distant metastasis. On examination, there is swelling present in front of neck 6 into 6 centimeter, moving well with deglutition. Margins are well defined, surface is smooth, and it is firm in consistency. There is no enlarged cervical lymph node, and examination of other system, abdomen, spine, pelvis, ribs, long one appears to be normal.
Clear to all of you? The advantage is that you understand how to go about presenting and not taking a lot of time to. What's your diagnosis now? Excellent summary. Any point, Dr. Umesh? Summary, now diagnosis.
A 50-year-old postmenopausal lady presenting with solitary thyroid nodule with no pressure symptom and with no clinically euthyroid and no clinically euthyroid with no pressure symptom.
Let's make it better, Abhinav.
50-year-old postmenopausal lady with a benign, non-toxic solitary thyroid nodule with no pressure symptoms.
Repeat that now.
51-year-old postmenopausal lady presenting with benign, non-toxic,
Presenting is over. Now the diagnosis.
benign, non-toxic solitary thyroid nodule with no pressure symptoms.
Now this gives 4 points to us. Why do you say it is? What is this? Why do you say it's a solitary thyroid nodule?
So there is only one nodule is palpable, rest of thyroid is not palpable, so it is a solitary thyroid nodule.
That is the definition of solitary thyroid nodule. Very right. So you got the definition. Can you repeat that?
So, the solitary thyroid nodule, the nodule which is present in the thyroid region and no other thyroid gland is palpable.
Therefore, the definition of multinodular gland.
So
It can be asked the other way around also. How do you define a multinodular gland?
So nodule is palpable in the thyroid region, along with that the rest of the thyroid gland is also palpable.
See, either the nodules are more than one, or the nodule is palpable along with the rest of the gland also being palpable. That will become a multinodular gland. So it is a solitary thyroid nodule, I accept it. Now, why do you say it is benign?
So there are in history,
Points in history.
So there is no suggestive of fixed surrounding structure like difficulty in breathing, difficulty in swallowing.
Is that
and
the first
alteration
history you would
of
ask? You're right. Carry on in history.
And there is no history of sudden increase in size or any pain over swelling.
So there's no history of sudden increase in size, no history of pain appearing in a painless swelling, no history suggestive of pressure or infiltrative symptoms, not pressure symptoms. Hoarseness is an infiltrative symptom, not pressure symptom. Akash was asking, since there are no pressure symptoms, should we take a history of, should we do Coccus test or not? What are those pressure symptoms?
So pressure symptoms is difficulty in breathing, difficulty in swallowing.
Or the patient has tried her in a
voice.
particular position. Hoarseness is not necessarily a pressure symptom. Recurrent laryngeal nerve would have to be pressed in isolation to produce that, but it can happen also. There can be a direct infiltration. Infiltration means it has gone into the other organ. That is what is more important. I agree with you. The third thing you said, benign, non-toxic. Clinically, no. On examination, what are the features? You said on history, benign because of the features that you mentioned. Yes.
On examination, the swelling is surface is smooth and margins are very
See, nowhere are you taking into account the age, which is so important in any patient with thyroid swelling or any malignancy. Patient is younger.
She's 51 years old.
She's 51 and looks younger than that. Isn't it? Okay, 51. So that's a high risk area. So there should be a risk, there should be a point against it being benign. Next.
Subpermanent consistency, and there are no cervical lymphadenopathy, and other systems are normal. No distant, some suggestive distant metastasis.
Okay. Any questions on diagnosis?
Can I interrupt? What is a dominant nodule? Because there are different difference between a solitary
Define a dominant nodule.
a nodule which is only palpable and rest of thyroid gland is also palpable. That is dominant nodule. It's
First of all, remember this is a huge misnomer. But this is being used, abused, misused so many times. Dominance of a nodule is demonstrated based on activity. It's like if an 80 kg person is standing next to you, but he is sleeping all the time, you are 40 kg, who is dominating? So dominant nodule concept came because earlier days, for every thyroid swelling, there was a scan done. And the scan showed more activity. Clear? So the dominant nodule was a, don't use it with a kind of confidence that he's asked a very valid question. And especially as we go around, I've been doing these master classes for so many years now. And I hear it very commonly in the peripheral areas, still a prominent way of, or the dominant way of teaching about nodules. There's nothing like a dominant nodule anatomically. But having said that, you can't wish it away, it is there. And the answer is, if there is a goiter which is multinodular, it could have more than one nodule, or it could have a nodule with the rest of the gland being palpable. If the rest of the gland is palpable, there is only one nodule. That doesn't need to be called a dominant nodule. If the surface is nodular and one nodule is clearly felt, it is a dominant nodule. Clear? Any other question? Any doubt you can ask?
I have a doubt, sir.
Yes.
I mentioned it's clinically euthyroid and patient is having symptom of chest pain during exertion, palpitation, and facial puffiness. So how is it?
See, I tell you, your question is valid, but mere presence of one of these symptoms doesn't make her hypothyroid. You're suspecting her to be hypo or hyper?
So chest pain is present during palpitation. So I'm suggesting on some cardiac pathology maybe.
No. What is your problem? You are confused whether it is hypo or hyper or normal? Hyper. Now, there is rarely a hyperthyroid condition where the pulse rate would be normal. So, I am not saying that your question is invalid, but have it in relevance to the rest of the features. She has no features, she sleeps well, she has no features of anxiety. If any other patient with or without thyroid has these symptoms, he doesn't become hyperthyroid. So just because she's got a thyroid swelling, every symptom is related to thyroid may not be valid. Having said that, it's still valid to think about some relationship, but exclude other features. Are there any signs of thyrotoxicosis in this patient? And palpitation is a very, very misunderstood term by the patient, so be very careful. Bradycardia can also produce palpitation. Palpitation just means being aware of your heartbeat, which can be faster or slower. So it is not always tachycardia and palpitation. It could be bradycardia and palpitation also. Clear? So, yes.
Sorry to interrupt you, sir. Sir, about the facial puffiness, does it point towards hypothyroidism?
Now the second point, facial puffiness. So you are having a mixed bag of symptoms. So you'll be all over the place. First fix this puffiness business. What did she actually tell you?
So she told that she is having facial puffiness on and off, and usually on the starting of the day.
What is the most common cause of a puffiness that appears first time in the morning?
Nephrogenic cause.
Exclude other conditions. The classical renal puffiness is when the patient looks into the mirror, face is puffy. And naturally, as you go along by gravity, it drains up. Let's not make simple things more complicated.
She's having painkillers for chronic diet.
Yeah, she's taking NSAIDs.
And if she's taking NSAIDs for pain management, as Abhinav brought out rightly, then exclude there is a renal cause. But don't commit on any. But don't fix it with thyrotoxicosis or hypo. Like Shipra asked rightly, one feature goes in favor of thyrotoxicosis, the other one goes in favor of, so they neutralize each other in terms of being bogus. Right? Patient says, I sleep well, my appetite is normal,
There is no loss of weight.
there is no loss of weight. Why should you worry about? Those symptoms are far more important. If you look at the long laundry list of symptoms in thyrotoxicosis, you also have a few. And you'll certainly have more during the examination. You don't become thyrotoxicosis. Right? So we accept your diagnosis. How do you proceed quickly? We have 5 minutes to wind up.
Sir, I would like to confirm my diagnosis by imaging of neck, ultrasound neck, and fine respiration cytometry.
I have a little problem here for you, not because of you, but because of your examiners. So their understanding is a major problem. Many a times it happens. So don't say imaging and take a pause. I've always made it a point to insist, even in the master class that we had in Railway Hospital. Say that in one sentence, otherwise they'll catch you. Imaging, I don't do any imaging in thyroid. Do you do it? He may not be doing it, that's not your problem. But on that day, it's your problem. You also have to ensure that you give an answer that the examiner knows. Otherwise it becomes a wrong answer. Although you're right. But that's not your day to fight with anybody, You want to pass your exam. So the approach is, keep it in the middle path. And what is the middle path? Sir, I would like to do the fine needle aspiration cytology, preferably ultrasound guided. I've discussed it so many times, I think you must have heard me before. Why do I say that? I have already told you. Why ultrasound?
Ultrasound to look for extent of lesion, nature of lesion, whether it's cystic or solid, or any other nodes in gland, or any cervical lymph node, or invasion to adjacent structures like vascular.
Excellent, everything covered. So ultrasound is necessary. What is one thing missing, Nikhil, which can be added? He mentioned about, I know, you're concentrating on that. Size, side, everything. You can guide your FNAC to the...
It increases the yield of the.
So it will improve the yield of your FNAC. You can justify it, but be very careful. Say FNAC, preferably ultrasound guided, so that there is no confusion in the mind of the examiner. Otherwise, imaging, they get totally distracted. Okay, next.
Investigation to support my diagnosis, thyroid function test, X-ray test, PAU, indirect laryngoscopy, X-ray soft tissue, neck, epilateral, and other complete hemogram, liver function test. She's having cardiac symptoms, so...
Thyroid function test would be more important. You said that? I'm so sorry, I didn't hear that. You'll do thyroid function test in supporting a diagnosis.
Yes,
If your examiner says, what do you mean supporting a diagnosis? This is no logic supporting a diagnosis. It is again his problem, not yours, but that day your problem. Because even that examiner is your problem that day. Isn't it?
The last time I started with ultrasound and FNOC, then why you are not doing thyroid function test?
That's what I'm saying. So I understand your worry. But what we are discussing is the right way of doing it, but have that flexibility. You say, of course I'm going to do thyroid function. So how should you, if I was Mahinder, what will I do? Sir, I'll investigate this patient to confirm the diagnosis, support and stage and treat. To confirm, I'll do FNAC, preferably ultrasound guided thyroid function test. Before he breathes, you breathe. See, the problem is that we live in this world. We don't make it. Otherwise, you can make it as you want. The world is already there. So try to be safe and flexible. That doesn't mean you're wrong. But it's not always that you're right, you're appreciated. Very often, it doesn't work. Let's move on.
So first we have to do thyroid function test or go directly to imaging? Because
I think I answered that. Because nobody does thyroid function test immediately and get a report in 5 minutes.
So basically depends upon if we want to go preference of if it's proliferative or not. It depends upon the nature of whether the patient is hypothyroidism or hyper.
You see, the web chart that you showed had serious problems that day. I didn't want to stop you from going on with that. In practical management of AT guidelines, the investigation that you do, there's nothing like first and second. You're supposed to do them all on the same day. You live in a world where there is a problem. Now, FNAC does not do any damage to a patient who's got thyrotoxicosis.
Sir, she's having primary thyrotoxicosis, Graves' disease, then first we will go.
See, that's the problem. That day, when you get a copybook stuff and you don't think, and there's nobody to guide you into it. That's why your question is not absurd. But you will understand why I'm saying it. FNAC does nothing negative to a patient with a thyrotoxicosis. Tissue diagnosis or a cellular diagnosis is mandatory. Chart or no chart. But you will do the thyroid function test in a patient who is thyrotoxic anyway. Nobody is saying you will not. Even if she is not clinically thyrotoxic, you will still be doing it. So it doesn't even need addressable. right?
So what if the confusion is that NCCN guidelines say that we first do a thyroid profile and then according to the TSH levels we manage. TSH are low, then we need to undergo a thyroid scan if it's a solitary hypertension.
I was going to say just immediately after this, I'm going to say the same thing. If the patient is clinically thyrotoxic,
Yes, sir. Then you would go for TFT, then thyroid is.
then you go for a TFT and scan is done.
Yes, sir.
Otherwise, scan has no indication, no role in thyroid swellings anymore. It's one of the least
It's more of
preferred.
value in primary thyrotoxicosis because this is the TFT.
And I am yet to understand any confusion in this. We don't draw a conclusion the wrong way. You are in a setup where one investigation is done on Monday, the next one on Tuesday, then the third. This doesn't happen anywhere else. In a thyroid clinic, the same day all investigations are done. Patient comes fasting, blood is taken out for TFT, for hemogram, for every damn thing, also for markers. And you do imaging followed by FNA, same sitting. Based on the TFT status, TSH, if the patient is thyrotoxic, you go for scan. And it all happens under one roof. The confusion comes when you deal with somebody, like the next question that you will be asked by both your examiners is, do you do that in your OPD regularly? You would say no. And why are you telling me? So I am giving you an approach which will save you from all this trouble. How do I say 5 things in one breath? So I'll still have to say one thing at a time. If you just tell me I am Dr. Mahinder, अपना address नहीं बताओगे? My address is अपना वो religion नहीं बताओगे? I mean, it'll never end. But you will say something at one point. Are you following what I'm saying?
Yes, yes.
This confusion in that class, I did not stop you because I wanted you to finish, was mainly because of the rampant ignorance in there. You have to do all of them. But your examiner is doing what? If a thyroid nodule comes to me, if she comes to me in my OPD, what do I do first? I'll do imaging and FNA. If imaging is available. Otherwise, FNAC is the gold standard. Based on the TFT, scan. Is that clear to all? Everybody is okay with that? Let's move on. Let's save time. What is it if FNAC is equivocal and you have a suspicion of malignancy?
So we can
Okay.
repeat the FNAC once more time. We can repeat the FNAC.
You can take the FNAC from a different way.
That is why ultrasound guided FNAC is more useful. So that you can take multiple, and somebody who presented, how many times you should prick for FNAC? How many sites you should take it? At least 4 sites through one prick. Don't withdraw it out of skin. Go to 1, 2, 3, 4. And what is FNAB?
Spine distribution.
Oh, I understand. What is the difference? Yes, Abhinav?
The biopsy will let us know the history of the entire
It's
tissue.
a slightly wider bore needle to get some tissue. You'll be able to get a tissue. Now, what is it? What are the limitations of FNAC?
It will give only cytological diagnosis. There is no histological diagnosis. It will not tell about grade of the tumor, type of tumor, and between invasive and invasive and in situ disease.
What is the major problem with FNAC?
So if negative FNAC will not rule out malignancy.
So,
So false negativity, with a negative FNAC has no role. And FNAC is definitely operator dependent. If you don't get positive FNAC, it does not exclude malignancy. So because of false negativity, it is important not to rely entirely on FNAC. And what is the minimum biopsy in a thyroid swelling?
heavy.
So then you resort to heavy thyroidectomy. Why don't we do incisional biopsies in thyroid?
So if we are doing incisional biopsy, the next operation, if it comes malignant, next operation will be difficult. And
Okay?
So seeding of the malignant cells.
Seeding, next one. Seeding and spillage would be more or less the same. Yes, Yatiksha?
architecture is chapter.
Akash? Hemorrhage. It's a bloody organ, which bleeds. And can you damage something? Parathyroid, and you can damage anything. What is worrying is parathyroid and recurrent.
So it is by core needle or this is
Whichever, incision biopsy, core needle, whatever we call it. Core needle biopsy is also a type of incision biopsy, incidentally. Now, we are done with the FNA and the report is follicular neoplasm management.
So I will explain the patient about the nature of swelling, that is a follicular neoplasm. The 80% are follicular neoplasm are follicular adenoma, they are benign, and 20% are malignant. But if we are going for hemithyroidectomy because the swelling is located to one side, then if it's some malignant, then we go for reoperation. And if she has
Follicular neoplasm means you'll do what is the surgery you're going to do? Follicular neoplasm, what is the surgery, Salim, you're going to do?
Total year
Samrat?
total therapy.
Okay, Abhinav,
There are two opinions. If only one lobe
tell
is
us the
involved.
second one.
Sorry. Sir, only one lobe is
There are
involved.
various opinions.
Yes. Only one lobe is involved, then we can give the patient two options, either of total
Again,
thyroidectomy.
two options.
Either total thyroidectomy or hemithyroidectomy, and if it comes out to be malignant after hemi, then we'll need to.
No, sir, no, that's not correct. Your answer in the exam, follicular neoplasm, hemithyroidectomy. It goes for frozen or histopathology. Based on the histopathological report, you do completion thyroidectomy or you treat it by radioactive action. Because FNAC is not going to make a diagnosis of follicular carcinoma. Why detection?
So because the invasiveness of the tumor cannot be known by distance.
What do you mean by invasive
chest
resection?
tumor and vascular invasion is present in follicular carcinoma.
You cannot appreciate that, right? Good. So that is the treatment for this, for follicular neoplasm. If it is papillary,
Papillary carcinoma, then we have to go for total thyroidectomy.
okay. And can you offer hemithyroidectomy to a patient with papillary carcinoma thyroid also?
Sir, if the swelling is less than 2 centimeters and there is no history of radiation.
So I don't want to ask you what is the risk stratification criteria. I want to ask you what are the, asking you indirectly. So you'll do some risk stratification.
Yes, sir.
What are the various criteria for risk stratification in the thyroid swelling?
Age is,
We're talking about cancer now. Age is,
MS, masses. Age is for age,
which of them is post-operative?
masses is post-operative.
So let's look at the one which is most commonly followed.
Age is A for age, which is less than 40 years, and it is for female, it is less than 50 years, for male it is less than 40 years, and G for gender.
More than, high risk means more than.
More than, and G for gender, it is more risk in male.
G is not for
grade,
gender.
grade of tumor. Grade of tumor. And
Okay.
E for extent, and S for sex, female, size of tumor.
You are obsessed with that. Gender.
Size
That
of
you
tumor.
already mentioned in the age, no? Okay, size.
Size.
What size would make it bad?
Greater than 2 centimeters.
Abhinav, correct that.
Greater than 4 centimeters.
4 centimeters. 2 to 4 is the dicey the size. But ages, ages, masses, they all have one thing in common, age. Age is a very important risk factor. And you're right, less than 40 males are safe, or risk is low, and more than 50 females are at high risk. So females get a leverage there, but the cancer is commoner in females, ladies, outcome is better in females. It's more aggressive in males. Now the grade is a factor. What is masses standing?
Masses is metastasis. A for
Age again,
age again. C for completeness of surgery. And
completeness of thyroidectomy.
I for invasion, and S for size.
This you will know only, completeness of thyroidectomy can only be known after surgery. What would be a complete thyroidectomy?
So removal of total thyroid tissue.
No, that is English. What does it mean in the surgical sense? How will you know the patient has had an R0 resection of thyroid? Can you do some investigation later on which will tell you?
thyroglobulin.
Less than 1% of take on radioactive.
Less than 1% of uptake on radioactive iodine scan. Right? Let's move on to the treatment if she is medullary carcinoma on FNAC.
If medullary carcinoma happens, then we have to do other investigation like serum calcium, serum calcitonin, and urinary metanephrines, and ultrasound abdomen to rule out
So instead
pheochromocytoma.
of just rattling it out, you just say, I'll do investigations for the MEN syndrome. What are the types of MEN?
So MEN is MEN type 1, MEN type 2. MEN1 is pituitary tumor with parathyroid adenoma and pancreatic carcinoma. MEN2A is parathyroid hyperplasia and medullary carcinoma of thyroid and pheochromocytoma. And MEN2B is pheochromocytoma and medullary carcinoma of thyroid with mucosal neuronomas and marfanoid habitus.
Excellent. Now, if you have a patient with the medullary carcinoma of thyroid, this workup is mandatory. What are the types of medullary carcinoma that you have? Which are the types? Familial and sporadic.
Sporadic.
Which is commoner?
Sporadic is common.
Which is worse?
Familial is worse.
Why?
It is bilateral and multifocal.
Very good.
Presentation of the
Bilateral and multifocal. What would that mean if it is bilateral? Why does it become bad?
patient has undergone a total medication. Overall, the whole of travel.
It will be involving the lymph nodes early. What is the treatment of choice if this was the medullary carcinoma and the rest of the MEN tests are normal, there's nothing else?
Total therapy with central lymph node dissection.
You're right, the standard of care is total thyroidectomy with lymph node dissection. But if this was more than 4 centimeters in size,
Then we can go for MRND on right,
ipsilateral.
ipsilateral right. Left
MRND type?
side, type 3.
What is type 3?
When all the 3 extra lymphatic structures are preserved, that is excessive spinal nerve, sternocleidomastoid, and internal jugular vein.
But what all is removed?
The lymph nodes of the level 2, 3, 4. In the MRND, lymph node of the level 1A, 1B, 2, 3, 4, and 5 will be removed.
So when doing for thyroid, we generally spare the level 1 because it is rarely involved. So what we do is 2, 3, 4, 5 and 6. But MRND is right if it is more than 4 centimeters. How about papillary? No nodes, nothing palpable.
So there is no role of prophylactic lymphatic.
The term is elective neck
Elective.
dissection, not prophylactic. So we don't do any elective neck dissection. It doesn't increase or doesn't improve the overall survival. Clear?
Yes, sir.
Okay. How do you prepare her for surgery?
So first, I will check out thyroid function test and check out.
You've done everything. You've done all the tests. Why did you do X-ray soft tissue neck?
To see for tracheal position or any intestinal extension of thyroid, any compression of compression of trachea, or any cervical spine abnormality.
That will be X-ray cervical spine. Why do you need that? Anticipated.
Difficulty in intubation.
Right. Beyond this, what else do you do to prepare for surgery? What else do you do? You write? Will you do an indirect laryngoscopy?
Yes, sir, indirect laryngoscopy.
Why should you do that?
To find out the vocal cords function for medical legal purpose.
Not otherwise.
Suppose
For the baseline functioning and
Just do the check.